Great. Now that we've got the tech stuff handled. No, I didn't really have a question. It was just a comment, which is that I didn't hear a whole lot about the glaring lack of intravascular imaging in contemporary bifurcation trials as a 100% maneuver, which I think is probably what is going to make the biggest difference. We're talking about side branch coverage, carinal coverage, culotte versus DK crush, but really what it comes down to is how much room is in the vessel, right? How much real estate is there? You know, I don't subscribe to the idea that DK crush is too complicated, or that we shouldn't promulgate it as an optimal technique because it's done in really good hands, because you don't tell a surgeon to do a bypass an okay way. Do it properly, do it right. Don't put 3 stitches in, put 5 in. And we have the same responsibility to do the same job, right? So if you can't do it, learn it. If you can't learn it, send it to somebody who knows how to do it. That's the simple, basic perspective. But with that, now that I've hijacked the podium, I have the opportunity to talk to you a little bit about which stents to use. And I'll tell you up front that you can use any stent you want, period, okay? But the purpose of this talk is more to tell you what I'm thinking of when I choose a stent and what the important properties of stents are that are going to allow us to achieve the results that we want, whether it's DK Couloche or culotte or DK culotte or TAP or any one of the alphabet soups of bifurcation strategies that we now have at our disposal. These are my disclosures. So I won't spend much time on this because I think it's been discussed ad nauseum now, but EBC main and DK Crush 5 were different beasts, right? These were very different trials where they were done in different groups of patients at different ages with different bifurcation complexities. And what we probably learn from this is that yes, provisional stenting, when possible, is an optimal strategy. Less metal is better than more. But then in your complex bifurcation subsets, maybe a more complex strategy with more than one stent is an appropriate approach, or more than one mechanism of securing side branch patency is an optimal approach. It doesn't matter how you want to slice it. But how do we then determine bifurcation complexity and thus define your strategy and stent choice? Well, the problem with the left main is that it is a different animal. So let's look at this left main. What's the severity of the stenosis? Looks pretty bad at the ostium, right? Who would, just for a show of hands, say this is a 50% stenosis in the left main? Justifies treatment, right? 60%. 70? 80? How about 0? How about 0? Because this is a completely normal left main coronary artery. And this is the problem, right? This is not the same animal. We cannot line an angiogram up with the same coaxiality or orthogonal view planes that we can with some of the other coronaries because of the way the left main is situated, which is why we really need to use adjunctive technologies to define the anatomy that we're treating. So how do we really define anatomy? We've already heard about the definition criteria, so I won't belabor it. But what I will submit to you is that these are not easy things to define on an angiogram alone. And that's why you use intravascular imaging, so that you can lend clarity to this myriad of challenging detail and define very clear anatomy for yourselves. And based upon that, choose your stent. Do I need a stent with giant side cells because I'm going to be delivering, or I have a high risk of side branch compromise, so I'm going to need to deliver another stent through it? Do I need a stent that's going to be able to expand very large proximally and can remain small distally? Do I need a stent that's got 12 connectors or 9 connectors, or sorry, 12 cells or 9 cells or 6 or 8? Do I need 3 connectors because I'm going down a straight vessel? Can I do with less because I need conformability? These are the questions that have to come out, but ultimately they come down to simple goals. Basic things that we try to achieve. Safety, durability and efficiency, and efficacy. That's what we want out of every PCI, whether it's a left main bifurcation or a type A right. So how do we take the tools at our disposal to take us through to these 3 goals? Well, we start with our intravascular imaging, right? Which then will define for us the anatomy, the plaque composition, and the strategy, right? This was the sort of see, prep, treat general idea that we discussed yesterday. But then how do we take anatomy, plaque composition, and strategy and make it safety, durability, and efficacy with efficiency? There's some middle ground there, right? Well, this is where your bifurcation intervention comes in, and that's then accomplished with some sort of optimized stent strategy and choice, right? This is the work protocol or the workflow. So then when we circle in on the workflow, we have to pick our tools and our strategy carefully. Having set up that background, let's look at a case. This is a 55-year-old that I did not too long ago with the usual cardiac risk factors, who had had minimal medical care throughout his life because of bipolar disorders, a common reason for marginalization. So he came in with a STEMI, was treated at an outside hospital with balloon angioplasty, sent for surgery and declined. These were his films, right? So you can see that the circumflex is out, the LAD is out, there's a super tight lesion at the diag. This was the inferior STEMI POBA result, but there's still a lot of disease in there. And this is his heart. This is pretty bad, right? EF of 10 or 15%. I remember getting a chuckle out of the echo report because they said that the atria contract better than the ventricles. So this is one of those cases where we did viability, and as it turns out, everything was viable, so we were going for complete revascularization. So I won't belabor this. This was the MCS device implantation. These were the RCA results. This was the left system diagnostic. This was the quick cross of the mid-LAD CTO, where we did a DK crush to yield a reasonable final result. This was an OM crossing. This ended up being a provisional stenting strategy across the circumflex. That did fine too. Okay, this was your IVUS-guided PCI of the OM, and this is what the OM looked like as you scan back through it. Forgive me, I don't know why it's not playing. It's a little undercooked there at the proximal end, but this is where the stent terminated in the circumflex as you come back towards the left main, and then you have to do your left main bifurcation. So now this is what we've got. So we've now dilated the left main open on both sides, which is why it doesn't look as bad now. And you've got to do a bifurcation of the left main. So how do we then use the precision anatomy that we talked about to define the perfect stent strategy and stent? Well, remember the anatomy, plaque composition, and strategy, right? So on the anatomy side, the anatomy we learned was that there is a big difference between the left circ size and the left main size, right? It went from 3.3 to 4.5. There was disease in both limbs, and we needed to deliver gear into the mid-LAD past what would be a left main to circumflex stent. So it's probably a good idea to address that stuff, the distal disease first. The plaque composition was mostly thin calcium, so this is something we know how to deal with. We don't have to rotablate this or make it complicated. And it was mostly fibrocalcific in the circumflex. So we'd probably need a cutting balloon or something to be able to score this so you can get good expansion. And then finally, with respect to the strategy, well, the left main disease was there, but only with 50% disease at the LAD ostium. The left main was 70, side branch was important, one minor segment, long disease. So we chose, for safety, we wanted a stent that would have a high expansion range between 3.3 and about 4.5. For durability, we needed something that had high radial strength because we were going to be coming around a corner within calcific plaque, but we also needed something with longitudinal stent, longitudinal strength, given how big we were going to make this stent. We needed something that would make a turn, a 90-degree turn from the left main and the circ, without pushing in a guideliner, because we would hit the LAD ostium and potentially turn a one stent into a two stent strategy. And then, of course, for efficiency, we needed something that was going to give us easy side branch access in case we needed to jump back into the LAD and intervene upon the LAD ostium 50% disease, which is starting to get to the borderline of where we want to leave something. So we chose a synergy stent. As I said, you can use almost any stent. So the question is, did we choose well? Okay? So these are the labeled post-dilatation limits for the various stents out there, whether they're Resolute Onyx or Synergy or Xience or Osiris. Because we chose a 3.0 by 24 Synergy XD, recognizing that there were 2 connectors distally and 4 connectors proximally, we were confident in overexpanding the proximal edge with a 4.0 millimeter balloon up to about 4.3 millimeters. Off-label goes to 4.5, on-label 4.25, right? So in that regard, we had made a reasonable choice from the sizing perspective. But did it fit the rest of our needs? So from the durability perspective, the question we ask ourselves is, does our stent choice satisfy the durability needs for the plaque and for the location, right? So this is coming across 2 large carina, which means we cannot have a bunch of recoil, and the worst place for recoil is the circumflex ostium. right? So these are the characteristics of the various stents out there, where radial strength is equal to the stent width, the strut width versus the height cubed, right? So what we were able to define was that the radial strength of the stent that we chose was acceptable. And based on that radial strength, we had made a reasonable choice. It's not to say that, again, you can't use any of the other ones, but we chose a stent based on the size. But the size is only one component, so you've got to then back check whether or not the other things that you're looking at are going to satisfy your needs. So now back checking, I fulfilled my durability need. What about side branch access? Well, this is what it looks like when you want to put a non-deployed 4.5 millimeter non-compliant balloon through the side struts of a Synergy stent without it attached to anything, right? So this was just a bench test that I did where I deployed the stent and I put it on a blue towel, put 2 wires through it and moved a balloon back and forth. And you can see that it actually maneuvers pretty easily. And that's because the nature of side branch cells on Synergy stents is very large. It gets up to 3.8 millimeters at the beginning. That's the circular cell diameter, with its maximal expandable cell diameter up to 7 millimeters. That's very, very large. That's as large as you're going to need to cover the ostium of an entire vessel, let alone to deliver a crimped stent. So that satisfied our efficiency and our durability needs as well. So our plan was, as we mentioned, address the hemodynamic support, address the distal disease, and then stent back from the left main, stent back from the circumflex into the left main, and that's what we did, right? So we went PCI circ back to left main with a pot, using a 4.0 balloon in the left main going up to about 4.3, and then using a 3.0 balloon at high pressures in the circumflex right across the ostium. And for what it's worth, when you're in a stent, and this is experiential, you can be pretty aggressive with your NC balloon dilatation outside of a ton of calcium at the level of the bifurcation. You won't perf, and you're probably going to be okay with respect to carinal shift so long as you have access to the side branch. And so this was the IVUS. And if you look in the left, this is the circ going back to the left main. So this stent is fairly well expanded, okay? The minimal stent area here ended up being sort of somewhere within the 10 range. And then this is the IVUS coming back from the LAD to the left main. So a reasonably well-maintained lumen, nothing terrible, no metal protruding in towards the ostium of the LAD. And so the question of do we need to stent the LAD, I think was reasonably answered with the intravascular imaging, and that the minimal lumen area at the level of the LAD ostium was big, but for what it's worth, we threw an IFR wire down, and this was the IFR. So with an IFR of 0.96 and a minimal lumen area that was over 6 at the LAD, we left it. So this was our final result. Okay, we were pretty satisfied with this. The whole thing, again, took only about 24 cc's of contrast. And so the lessons that I learned from doing this case and thinking through the stent choice was, you've got 3 things that you need to understand: the anatomy, the plaque composition, and the strategy that you're going to execute. Once you understand those 3 things, you pick a stent that is going to satisfy your size needs, because those are the things that are limited by your stent platform. But then you back check whether or not you're going to have troubles afterwards bailing yourself out if you need to, and that includes side branch access and the likelihood of recoil of your radial strength. And the goal is, of course, to use all of the information that you have to choose the stent that's right for your case. Thanks very much.
Thank you, Dr. Sanjog Kalra, for the excellent talk on stent selection.